First of all, I'm delighted for the first time in my life to be to South America. 3 hours now I've been here, and I'm very much grateful to Enrico sitting here, who I tend to meet in different places throughout the world, and whom I learned a lot from. As you heard, I come from a very small country, Denmark, which population is 1/3 of Rio's. So you probably wouldn't even find it if you went there to look for it, but I'm very pleased to be here. So what's the evidence for carotid intervention? It's very strong, but it's historic now, and the evidence for stroke prevention by endarterectomy in symptomatic patients especially. These patients were randomized 20 years ago. What about for asymptomatic patients? Then the historic evidence is weak, and these patients were also randomized a long time ago. And by the way, there's no evidence for stroke prevention by stenting. Now we're talking about it. So what has happened the last 20 years? Well, medical treatment has changed a lot. We got newer and better antihypertensive agents. We got more aggressive treatment goals. We got newer antiplatelet agents. Sometimes we do a dual therapy. And of course, we got statins. So it's much better. So the improved medical treatment, would that not affect the results of intervention? I think the benefit of intervention with regard to stroke risk reduction in both symptomatic and asymptomatic patients would most certainly be less today. I think plaque stabilization by drugs may reduce the time window for intervention in symptomatic patients. And I think that drug treatment may eliminate the benefit for endarterectomy in asymptomatic patients. Let's look at the classic NASCET main result in patients with severe disease. We saw an 16% absolute risk reduction and a numbers needed to treat of 6. Very efficient treatment, very good results. And if we look at the reanalysis that was done of both the NASCET and the ECST trial, where they looked at what was the effect of age, where we saw that the older the patient was, the greater the benefit. But we also saw that the more recent the symptoms, the more benefit you have from operation. And put in this slide, you see the absolute risk reduction in severe lesions and in moderate lesions, depending on when you were operated with respect to your index event. And you see that those who were treated early, within 2 weeks, had up to 30% absolute risk reduction, bringing numbers needed down to 3. But on the other hand, you see on the right side of the curve that if you were treated up to 12 weeks after your symptoms, the effect or the benefit was almost gone. And when do stroke patients have their second stroke? That happens to happen within the first few days if you look at this curve from the Oxford Express Clinic. And what you should also notice is that the difference between these two curves is the historic between treatment regimens, where the purple one, the top line, is what the stroke risk was before 2003. And then they changed the management and was very aggressive with medical treatment, and you saw that they more than half the risk. But still notice that new strokes occur very quickly. So how fast should we intervene? Probably as fast as possible. We should probably think like cardiologists, although I hate to quote cardiologists for anything good. I think they were wise on this one. You know, treat them fast, and we should probably do the same thing with patients with symptomatic carotid patients. And if not that, then subacute the next day. But we have a lot of myths. I was brought up with that if you have a stroke, you have to make your brain stabilize, and that have to take at least 8 weeks. But I think we have many good surgical series from institutions have shown that that's rubbish, and you can operate on patients with more or less the same risk, or only slightly elevated risk if you do it fast, and then we know the benefit is much greater. So the status for endarterectomy in symptomatic patients is that it is probably still beneficial for severe stenosis if performed soon after the index event. Endarterectomy may be beneficial in moderate stenosis if treated immediately. Effect is greater the earlier the operation, largest effect among older patients, and greatest effect for men. But I would still say we need new trials, and I'm happy to say that the ECST2 trial is now funded, and they will begin to randomize patients early next year. What about asymptomatic patients? What is the biggest problem for a patient with an asymptomatic carotid stenosis? Is it ipsilateral stroke? Now this slide shows the main result from the ACST trial, the most recent asymptomatic trial from Europe, which showed a benefit, not very big, but a benefit after 5 years. But what they didn't tell us very clearly was that the risk of death is much higher than the risk of stroke in asymptomatic carotid stenosis. Similar to the discussion we had with Jose Fernandez on patients with coronary disease and asymptomatic carotid stenosis. Carotid stenosis signals mortality much more than it signals stroke in asymptomatic patients. If you look at some of the recent trials that look at the natural history of asymptomatic disease, here's a Dutch study where they followed 2,600 patients with vascular disease, among whom 221 had a 50% or greater asymptomatic carotid stenosis. And if you looked at their 3-year risk of having an ischemic stroke, it was 3% over 3 years, which gives you an annual ipsilateral stroke rate of less than 1% per year, whereas mortality was 7 times higher. And if you look at the temporal change in risk of stroke in those trials of asymptomatic patients that has been reported the last 25 years, you can see a clear trend that the risk of stroke in asymptomatic carotid stenosis patients has gone down from 3 to 4% per year to today less than 1% per year. So if you look at the ACST, who a few weeks ago reported the 10-year results in The Lancet, they claim that the operation still works because there's still an absolute risk reduction of 0.5% per year, which means that you have to operate 200 patients to prevent 1 stroke in 1 year. 200. Well, if you make a lot of money, that's probably the best thing that's about it, because it's not good for the patients. But if you look at the 2 curves in the last 5 years of this graph, you can see they are parallel, which means that there is no benefit of endarterectomy in asymptomatic patients. So the facts is that asymptomatic carotid disease signals high risk of cardiovascular events, low risk of stroke, and minimal effect of surgery, if any, I would say. So in conclusion, endarterectomy probably prevents stroke in recently symptomatic patients with carotid stenosis, most benefit in patients with severe stenosis, and endarterectomy for moderate stenosis should be performed immediately. Medical therapy is effective in patients with carotid disease. I did not have time to get into that in detail. And it's probably much more important than surgery in patients with asymptomatic stenosis, at least until we get better selection criteria, but that's a whole different deal. Most importantly, we do need new trials, including a medical arm, and new trials are not unethical. Thank you for your attention.
Thank you. Vamos agora ouvir os comentários pelo Dr. Carlos Eduardo Virginie Magalhães.
Bom dia a todos, obrigado pelo convite. Quero parabenizar a apresentação do Dr. Henrique, muito boa. Falando de aspectos sobre a cirurgia e intervenção de carótida pouco usuais, a moda agora é dizer que a cirurgia de carótida em assintomáticos ela não tem mais lugar, esse é o chavão que se fala, mas ainda existe muita coisa a ser discutida. Primeiro, lembrar que não, como ele falou, que não atrai os efetivos, né, randomizados, comparando o tratamento clínico, tratamento médico, com a intervenção. E lembrar que quando se compara os dois, nós comparamos a intervenção mais tratamento clínico versus tratamento clínico somente. Então, a gente acredita que o resultado cirúrgico também vai melhorar se a gente mostrar esse peso das novas drogas para tratamento clínico. E o que eu achei muito interessante também na palestra que ele fala é que o resultado da cirurgia, da intervenção, seja angioplastia, seja cirurgia aberta, realmente ele é muito bom quando é feito logo após o evento, de uma forma precoce. Provavelmente, pacientes que tiveram algum evento, algum ataque transitório ou a própria AVE, com mais de 3 anos de evolução, eles não se beneficiam de cirurgia aberta ou de angioplastia. Enfim, eu acho que tem que pensar cada vez mais em ser mais criteriosos na indicação cirúrgica, seja angioplastia, seja cirurgia aberta, para a carótida, e não se basear apenas em números que já foram, como há 10, 20 anos atrás, já foram mais os dogmas, 70% para sintomático, 60% para assintomático. Isso claramente caiu por terra já. Eu acho que a gente tem que pensar realmente em individualizar cada vez mais a indicação do tratamento cirúrgico da carótida. Muito obrigado.
Obrigado, Dr. Presidente.
Thank you very much for that comment. I agree totally, and I know this was a very black and white talk, and I will also agree that any asymptomatic stenosis is only asymptomatic until the patient have a stroke. It's just not very many of them, and we have to be better in finding them. Thank you.
Thank you. Vamos ouvir então o professor Frank Witt.